Welcome to Medicine in Our Backyard. I'm Adrienne Windsor, and I can't tell you how happy I am to be here tonight. Because the first week in December, I cracked my kneecap, and I spent 2 months in immobilization. So here I am walking. Isn't the body wonderful? So let me say, this is a series that's presented by the Newport Beach Public Library Foundation in partnership with UCI Health. And we have tonight our two generous sponsors who've been with us since the beginning of this program more than 10 years ago. Mike and Polly Smith, would you both please stand? We're just so thrilled to have them here. And I would also like to acknowledge Kunga, our program director, Jane Merritt from UCI Health, and Jerry Capel, our CEO, who just walked in. They all help make this program possible. So a quick bit about us. The Library Foundation is membership driven, and our mission is to support the library with valuable resources and programs and services. Can I see a show of hands? How many are members? All right, well, if you're not, please join. Please do it right away. The foundation provided this seat you're sitting on. We've done all kinds of things for the library, the media lab, computer desks, e-books for the library. We even have provided tech toys. How many of you are into tech toys? Oh, Jan, okay. She may be the only one. We also sponsor the programs that we have here. This Medicine in Our Backyard, which is free, our financial workshop, our book discussion group, these are all free. We have the Witty Lecture Series of distinguished speakers and distinguished leaders. And then we have our distinguished author series, Library Live. So the foundation is doing a tremendous amount. It's also raising half of the money for that building that's being built out there in Avocado. If you've driven by and thought it was moving slowly, they are saying it will be done by next December of 25. So stay tuned. All right, our program tonight will conclude with Q&A. So I request that you hold all of your questions until the end. If you haven't silenced your phone, I hope you'll do it right now. And it's my pleasure to introduce tonight's speaker. Dr. Irmina Gradus-Pizlo, she says we can call her Dr. Pizlo, is a UCI Health cardiologist who specializes in heart failure and adult congenital heart disease. Her clinical interests include echocardiography, hypertension, coronary artery disease, myocardial ischemia, and left ventricular function. I wonder how many of us have been through some of this. She earned her medical degree from the Medical University of Warsaw in Poland. After completing an internal medicine internship in Poland, she moved to the United States and worked as a guest researcher at the National Institute of Health and did postdoctoral work at the Cardiology Institute at the University of Indiana in Indianapolis. There she completed an internal medicine residency and cardiology fellowship. At the Indiana Health System in Indianapolis, she built an advanced health care program, first as an outpatient clinic for patients with heart failure. That's why she's so qualified to be talking to us tonight about managing our cardiovascular issues. And while she was there, she developed a program for dealing with adult congenital heart disease issues. So please join me in welcoming our speaker tonight, Dr. Pizlo.
Good evening. It's a wonderful audience. I really appreciate you guys coming. So I would like to kind of chat with you about Guideline to Living Long and Well. And this is kind of overarching cardiology. You saw that I've done in cardiology so many things, from echocardiography to the congestive heart failure, ventricular assist devices, transplants, adults with congenital heart disease. But then I'm also fascinated with all aspects of prevention. After working for more than a decade in the sort of terminal situations of heart transplant and ventricular assist devices and heart failure, I thought we are putting so much resources into all this, when in fact, if we directed those resources to preventing heart disease, starting early, not letting people walk around with high blood pressure and high cholesterol, how much would we be able to achieve, right? And I believe that it's probably a lot, for sure. So cardiology in general provides expert care to your heart and blood vessels. When we are talking about heart, it's muscle, it's electrical system which drives the heart, and the vessels which feed the muscle and the electrical system. There are also large vessels in the body, which we cardiologists kind of take a look at, the aorta and the other vessels, check your pulses and stuff. So common cardiac problems which we deal with is coronary artery disease, myocardial infarction if those arteries are getting blocked, cardiac arrhythmias when the heart electrical system gets kind of confused and goes short-circuiting itself, and that's atrial fibrillation among other things, very common. Heart electrical conduction problem, which require devices like pacemakers, and heart muscle disease, which leads to heart failure. When we are facing the patient, we have to start with getting the diagnosis, what's going on. And first in line is evaluation of symptoms and risk factors. And believe it or not, but those are our best friends, the symptoms, right? Because if patient doesn't have symptoms, we won't meet them. So shortness of breath, chest pain, palpitations, this is what brings you to cardiology attention, right? We sort of aspire to see you sooner in a preventive cardiology to assess a little bit more of a risk profile, but those are the entry points when you meet us, most of the time. Some people have fatigue and dizziness and family history of heart disease. This is very important. I joke that the best genetic testing is to talk with your family about your family history, right? Because that's important. You really, my husband always says, you have to pick your parents carefully. Agree with him. So when patient has those symptoms, we would like to see them right away. They all sound scary. You will not believe how often people walk around with shortness of breath and just think, oh, I just gained some weight, oh, I am deconditioned, and just basically justify everything what's going on and not go to the doctor or not make that call. There is a very important role of a caregiver here, because many times it's a caregiver who says, enough of this, I'm making a call. And just as kind of caregivers, make sure that you're allowed to do that, okay? And you frequently will have to drag that patient kicking and screaming to the doctor, but it ends up all well. So what are the risk factors? The most common is hypertension and high cholesterol. The obesity is something which we deal with quite a bit. And all those, I hit the wrong button, and all those three are, if the patient has all three of them, the hypertension, high cholesterol, and obesity, then we are talking about a metabolic syndrome. That frequently leads to diabetes, and of course, all of this is multiplied if the patient uses tobacco. And physical inactivity is sort of next in line among the risk factors. So, hypertension, do you guys know what's the goal for healthy blood pressure? Anybody?
120/80.
How about that? Bravo. Now, that's exactly right. And everything above those numbers is elevated blood pressure. And then when we go into above 135 and 85, we are starting to talk about hypertension. And with that, there are several stages of hypertension, but every 5 millimeter increase in that baseline blood pressure is going to cause trouble. And the most common trouble is development of heart failure, stroke, kidney disease, and heart attack. So that blood pressure is something which we are very committed to manage well. Now, I frequently have patients coming to my office with the list of blood pressures which are like all over the place. I mean, 180, 130. And the question is, when do you check your blood pressure? Right? So very frequently, I have the situation where the patient says, I'm not feeling well, I have headache, let me check the blood pressure. No, I don't want to know. This is a stress response to pain, right? This is not the blood pressure, which is the baseline blood pressure, which we are after. So if you want to check your blood pressure, you can check when you have headache, but you need to know how to interpret that, right? And by golly, don't check it again if it's 165/95, because what will it do? It will go up, and then you'll get nervous, and you'll check again, and it will go up. And then you're going to call some helpline in some office, and what will you hear? Go to the hospital. It's like a clockwork. Once a quarter, I have a patient who comes to me after emergency room visit for that particular reason. So if you're taking blood pressure medications, take an extra pill at that point. Don't check blood pressure, okay? Go kind of rest. If you feel like you have shortness of breath or chest pain, that's another story. You just go to emergency room for that. But don't get that blood pressure going because you're nervous, because you don't feel well to start with. Okay? Any questions about that? So, great answer about the blood pressure. And my kind of ask from you is don't minimize the blood pressure. If your blood pressures are high, there are so many good medications we can help with to lower it. The problem is the blood pressure is unfortunately not our best friend in a sense that it doesn't hurt. People feel well, right? If you have shortness of breath, you'll come to see me. If you have high blood pressure, you don't know about it if you don't check it. Same with cholesterol, right? So high cholesterol. We'll talk a little bit more about where sits the good cholesterol values, and it's an extremely hot topic right now. So we'll come back to it. And then obesity. You all are familiar with the new developments of injectable and oral medications to treat obesity, and it will change the world around us. I'm pretty sure about that. First of all, it led to physicians going to the Capitol Hill and arguing that obesity no longer is some style or lifestyle thing. It's a disease. So for the first time, it was reclassified as a disease, which requires therapy. And one of our doctors here is a leader in obesity management, Dr. Bhavani Nadaswaran. She leads the obesity clinic, and she is board certified in obesity management and stuff. Tobacco use goes without saying, right? If you smoke, things are really not going to go well. It's rare that patients who are lifelong smokers don't have a cardiovascular disease. And physical inactivity, that's also something which we can manage. So what do we do? When we talk with you, we talk about your symptoms, we talk about your risk factors, then we go into physical examination, listen to your heart, check your blood pressure, check your pulses, check for swelling, look at your neck to see how full is the tank, the veins are distended, listen to your lungs, and then we order blood work and diagnostic tests. So basic blood work which cardiologists need is the blood count. Because if patients have anemia, they will be short of breath. They may even have chest pain if it's profound. So that's why we check it. The comprehensive metabolic panel, liver and kidney, are the target for this test. Fasting lipid panel. How many of you had your fasting lipid panel? Hands up. All right, that is a good show of hands. Mm-hmm. And how many of you had lipoprotein little a checked? That's less, right? Yeah, the lipoprotein little a is a new marker which is enhancing the risk profile of patients with high cholesterol. About 7% of population has it, and it's good. It's check it once. We don't have specific treatment for it. We just have to adjust our therapeutic goals when we know somebody has elevated lipoprotein little a. There are ongoing trials of new medications which will target specifically lipoprotein little a. And those trials, many of them are in a phase where the patient recruitment is ending, and now they are in a follow-up phase. So within the next 3 years, probably we will know whether there is a medication which we can target the lipoprotein little a. For those of you who have elevated lipoprotein little a, or who will find that they have elevated lipoprotein little a, it's always good to know what's your C-reactive protein level, because the more inflammation, the more the lipoprotein little a may play a role in increasing the risk. What do we do now? We lower the LDL cholesterol in patients with elevated lipoprotein little a as low as it goes, basically below 55. So common diagnostic tests, EKG tests for electrical system and electrical conduction. In Indiana University, I actually trained under Dr. Charles Fish, who was basically a pioneer of EKG, remembers times when the EKG was like 2 leads, then 3 leads, and so forth. And he was coming, and this was paper time, so the fellow was me sitting on the left side with the pile of EKG, which I was supposed to pre-read. He would sit in the center, and the student on the right side. And he would read like this, I kid you not. And then something would interest him, and he would lean forward and start drawing how electricity goes around the heart. And I would understand all of it at that moment, and only that moment. So he really was an expert. And one time, one of the brave fellows put a EKG of a dog in that part. And so he would read, normal dog. You know, cardiologists sometimes make jokes. But what we know, EKG is kind of low-level testing. It's not something which will tell you a lot. It will tell you whether you're in normal rhythm or not. It will tell you, potentially suggest whether there was a heart attack in the past, but not necessarily. It's just the first step. Echocardiography. This is a test where the ultrasound of the heart is taken, and this tests the heart function and structure. So it looks at the muscle, at the chamber sizes, how the blood is flowing using the Doppler, whether the valves are working, leaking, blocked. It's all this information. It also is giving us information about how the heart is relaxing. And, you know, when I was a fellow, this is 1990s, right? Okay. Long time ago. We were starting to have the concept of diastolic heart failure. Not only systolic heart failure, which is squeezing, but also relaxing, and how important heart relaxation is to the heart function. I'll come back to that. Heart is a pump. It's like an engine. We have to understand that it's squeezing in and it has to relax. Echo is providing all this information. What it doesn't do, it doesn't look at the heart arteries. They are too small to do that. Then event monitor and Holter monitor are monitors which you wear for a period of time to see what kind of heart rhythm do you have. Stress testing is when you come with symptoms of chest pain, shortness of breath, or fatigue, to see whether all those symptoms may be due to a blockage in heart artery. Then, if there is a suspicion, we do cardiac catheterization or cardiac CT, coronary angiography, MRI, or PET if indicated. So we have lots of tools. This is anatomic drawing of the heart. You see here the left atrium, the upper chamber, the mitral valve, which is between the left atrium and the left ventricle, the left ventricle here, and the aorta here. Aortic valve right there. And this is how it looks on the echocardiogram. Left atrium, mitral valve, left ventricle, septum. You see that we can measure the thickness of the heart and the aorta here. So when the patient comes complaining of chest pain or shortness of breath, the doctor would want to have stress test. There are multiple types of stress tests, and by far, exercise stress testing, if a patient can exercise, is the best stress testing. There is treadmill and there is bicycle. We have supine bicycle for those folks who can exercise but maybe not very stable on a treadmill. And then you may add echocardiography to that. So take images before and after, both on treadmill and bicycle. And if the patient cannot exercise, we can exercise the heart using a medication called dobutamine, which will increase the heart rate. So the patient is relaxing. Let's say they need to have vascular surgery on their legs or knee replacement. We cannot put them on a treadmill, but we have suspicion that there may be something there that needs to be investigated. They lay on a table, we take pictures before, and we start infusing the medication. And at certain stages and certain points, take pictures again to see how the heart, which is squeezing much faster now, whether there is no lack of blood supply. And if there is, the area which is hurting will stop moving. The other walls will be moving, and this one will not. And hey, we will know it doesn't have enough of a blood supply. Okay, that's how we figure it out. Similarly, there is nuclear stress test, treadmill or LexiScan, and those are going under the nuclear camera. Those are based on a different principles. The heart is not asked to exercise with your treadmill exercise or with dobutamine. These medications are dilating arteries. So the baseline images are obtained, and then the medication is given, and arteries dilate. The blood flow increases to the areas where the artery dilated, and it shows more nuclear impulses from the heart in that area. If you have a blockage, that artery will not dilate, right? So there will be a difference between the place where arteries are flowing and the place where arteries like squeezing by. So exercise stress testing is the best because, first of all, it provides information about functional capacity, and it's information for you and for doctor, and that's very important to just assess your longevity and all that. If you have normal EKG, treadmill is adequate, but patient needs to be able to exercise and it needs to be safe. So the stress test can be done both in patients who don't have diagnosis of coronary disease, just to kind of check out the symptoms, or in patients who already have diagnosis of coronary disease to see if they are doing well. This is a setup of the treadmill stress test. Blood pressure, electrodes, treadmill, EKG machine, can be echo before and after. Now here is something you ladies need to know about. This is the most common protocol which is done on a treadmill stress test. It's called Bruce protocol. When the treadmill stress testing was developed, it was first tested and developed for military. So look at the ramping up of this, right? You're going 1.7 mile, 10% grade, 2.5 mile, 12% grade, 3.4, 14% grade. So us females sometimes are not keeping up with that treadmill, okay? And it's just because it's a tough one. So you may want to talk with the technician to do a modified protocol. It will just take longer, but not necessarily cut you out, right? Because it's such an aggressive protocol. Although I've seen many females ace it without a problem. But I always warn them, just make sure which one you're more comfortable with. So this is an example of the echocardiography during the stress test. And there is the area which is marked here, like looks thinned out, and it's in the left anterior descending artery. Patient was referred for cardiac catheterization. Hello, you can see blood is flowing. There is a little thread-like area here, a blockage. So this is an example of what stress test can do for us and what angiography looks like afterwards. The LexiScan stress test, the one nuclear stress test, and that injected the medicine called bragadenoson, and you monitor the patient, heart arteries are dilated, and again, it's used for patients who cannot exercise. So, okay, you had a stress test and you did great, right? So for how long usually does it last, the good news? How long can you be okay? Usually 3 years are really good after a stress test, if you don't develop new symptoms, right? But if you did good on stress test, by pulling all the data, it's good predictive value that you will not have problems for 3 years. Now, new kid on the block called coronary angiography. I'm sure you guys heard about it. Coronary angiography, coronary calcium score. Those are things which are very popular now. They are excellent in providing direct visualization of heart arteries. They can tell us about blockage in the coronary artery. The coronary CTA, the angiography, if you have a lot of calcium in arteries, finding a blockage may be difficult because the calcium shadows. So people with high calcium score, the coronary angiography may not be, by CTA, may not be the best method. Now, coronary CTA is thus excellent for people who are less than 65 years old, because above that age, we usually see lots of calcium. However, if there is absence of calcium in coronary arteries, it's an excellent predictor of low risk for coronary artery disease. Okay, total cholesterol levels. If you Google cholesterol levels, this is what you will get. Normal, less than 200 for total cholesterol. Borderline high, 200 to 239, and high above 240. The LDL, optimal, less than 100, near optimal, 100 to 129, and then borderline high, up to 159, high above 160, and very high above 190. So even with now HDL, men should have HDL more than 40 and women at least 50. However, even if 2018 guidelines, they recognize that the principle is the lower is better. And studies clearly suggest that the optimal total cholesterol level is about 150 total, and LDL below 100. And even lower when you already have heart disease or stroke. Let's go to European guidelines. They were 2023, and they recommend that people who already had heart disease and a recurrent event should have LDL level less than 55, right? Woo, that's a goal. High risk, people with elevated calcium score, risk factors, less than 70 LDL level. People with moderate risk, less than 100, and low risk, less than 116. So you see that those values go even lower, right? And if you look at the Society of India, their recommended LDL level is less than 35. That population is very vulnerable, even though many of them are vegetarians. We'll let them ring. That's okay. Don't worry about it. Those phones, you know. Yes. Electronic leashes. Treatment. Lifestyle modification. Eating hot fat diet will increase your cholesterol. And if you gain weight, it will increase your blood pressure. I always tell my patient, my strongest blood pressure medication is weight loss. There is second to none. And vice versa, you frequently have somebody go to the hospital with some acute illness like pneumonia, and that person was well controlled on the blood pressure was well controlled on 3 antihypertensive medications. They are discharged from the hospital with the same 3 antihypertensive medications, but they lost 8 pounds, and they come to my office dizzy with the low blood pressure, right? Have to back off those blood pressure medications, right? We learn from experience with bariatric surgeries that those patients, we have to just back off all medications after that surgery. But natural weight loss for this reason or that reason will do the same thing. Another, not as strong, but significant lifestyle modification for blood pressure is regular exercise. And sleep. Heart loves good night's sleep. And if there is any question about sleep breathing disorder or restless leg syndrome or anything that disturbs the sleep, I highly recommend to talk to sleep specialists. This discipline basically developed during my professional life, and they are extremely helpful in helping us with modifying that problem. The second comes medication. They do wonders. We have so many fantastic medications right now. We'll go through the groups. Then procedures, the cardiac catheterization if needed, stent placement. If patients have arrhythmia, ablation of those arrhythmias if needed. Nowadays, valve replacement through a catheter with TAVR valves for aortic valve. Amazing. Clips for mitral regurgitation. Clips for tricuspid regurgitation. All this is happening right in front of us. And then referrals for open heart surgery if needed, for bypass surgery or valve replacement surgery for well-qualified patients. So there are multiple things which we can do, but I want to underscore that many of those needs here can be prevented. Okay, so medications. Beta blockers like metoprolol, carvedilol, bisoprolol, you probably are familiar with it. You guys probably know that the medications ending sort of give them their family name, right? Metoprolol, those are lols. Carvedilol, right? Beta blockers. Then ACE inhibitors like lisinopril, right? Enalapril, those are ACE inhibitors. Angiotensin receptor blockers, losartan, those are TANs, valsartan. Medications like Entresto, which I'm sure you see advertisement on TV for Entresto, specifically for patients with congestive heart failure. Calcium channel blockers like diltiazem and amlodipine, diuretics like furosemide, spironolactone, hydrochlorothiazide, statins like atorvastatin, and antiarrhythmic drugs. Which group would you like to talk about?
Betas. Start with betas.
Betas. So betas, statins. Beta blockers kind of raised to the forefront after acute myocardial infarction trial, clearly reducing mortality. They're mostly used for ischemic heart disease and heart rhythm problems. In the past, they've been used a lot for high blood pressure. However, now we have better medications, so they are not regarded as a blood pressure medications anymore. But mostly the acute myocardial infarction. And when I was a fellow on beta blockers, there was a big warning black box. Do not use in patients with heart failure. And then Swedish people kind of got that myth busted by showing that they improve survival in patients with heart failure. Except when we tried it, my teacher was like, what were those Swedish people drinking? Because we didn't know how to do it. And a secret is to start at the low dose and go slow. Okay? Don't put the dose which you would like the patient to be. Make sure you just go slow and up and up and up, and you can improve that cardiac function tremendously. Start low and go slow. So they are mainstay of guideline-driven medical therapy for patients with congestive or systolic heart failure. Somebody said statins. Ooh, that's a big topic, right? That medication group has their great followers and protagonists and antagonists, right? And there are patients who tolerate it beautifully, take it in the evening like multivitamin, and are happily observing the success with their LDL levels. And then there are patients who are not so lucky and who have side effects with statins. And those are real. So there are other alternatives for cholesterol management in this population, but still statins are the mainstay for the treatment of cholesterol. ACE inhibitors, lisinopril, losartan, like angiotensin receptor blocker, those are good blood pressure medication. They also are in the list of medications for heart failure management. Calcium channel blockers, heart rhythm and blood pressure management. Remember amlodipine, if you guys are on amlodipine, 10% of patients on amlodipine will develop swelling of the legs. So if you are on that medication and feet are swollen, you kind of, I'm the top 10%. And then the ACE inhibitors will cause cough sometimes. 1 in 10 patients will have this tickle in the throat type of a thing, and it will go away if you stop it. Okay. So I picked heart failure as a specific condition to talk a little bit more about, because it's the end of all problems, right? Cardiology got good at managing everything. We put stents for heart attack, right? But the heart gets damaged a little bit, and then we manage the cholesterol, and we manage the blood pressure, and we make people live long. And then they develop heart failure. So this is the heart failure, the way I see it. There is more than we see the eye, right? So, there was this kind of concept when we use the word congestive heart failure. There was a concept that when patient has shortness of breath and congestion, they are in heart failure, and then when they are no longer congested, they are out of heart failure, right? So it was somehow magically disappearing. We all struggled with this, and the society came with a timeline and stages of heart failure. And we have here a stage A, which is patient who is at risk of development of heart failure. It was kind of controversial, right? I have high cholesterol. I'm at risk of heart failure, stage A, right? Decades passed, and the patient develops asymptomatic heart dysfunction. Let's say they had a heart attack, their ejection fraction is 45, they never had symptoms or admission for heart failure, but their heart pumping function is already reduced. Well, that matters to be discovered, because those patients already need to be treated with beta blockers and ACE inhibitors to keep that heart pumping function up. The heart failure, the way we know it, is here, stage C, symptomatic left ventricular dysfunction. This is a patient who is short of breath, is not able to do regular activities, has occasional swelling, has to take all the medications. And then as the time passes, there is the drug refractory heart failure, the end stage heart failure. So once the heart failure is diagnosed, we really don't have this concept in heart failure and out of heart failure, right? It's once heart failure, always heart failure, and we have to manage it with medications. First of all, I hate the name of the disease, heart failure. I'm going to a patient and telling them you have heart failure. They're like, right? That's not a good disease. In Polish language, it's called circulatory insufficiency. That's a mouthful. French also call it that way, but here it kind of stuck to be heart failure. And I don't think it will change, but it's really insufficiency. So the scope and the burden of heart failure, at risk of heart failure, there are 60 million people in the United States having those risk factors. Stage B patients already having reduced heart pumping function, many of whom don't know about it, it's about 32 million. The patients who have heart failure and require hospitalization, it's 6 million, and stage D, they're about 200 to 500,000. So I want to pitch something to you guys. So here we are. Mortality for heart failure is 160 per 100,000 a year. And if you think prevention, once we turn 50, we all go through a very pleasant procedure called colonoscopy, right? And then every 10 years or so. PrEP, invasive, sedation, in hospital. Mortality for colon and rectal cancer, 16 per 100,000. And here we have heart failure with mortality 10 times higher. And there is no recommended echocardiogram, non-invasive, outpatient, right? Make sense? I wrote a proposal to NIH for that. They busted it. It was bad timing because all these preventive things were not in vogue, right? The prostate cancer screening, people realized that we create more trouble than it's worth. The breast screening also was kind of not. So prevention was not on top. I think I have to revisit that proposal. But does it make sense to you, right? So now that we have I have an encouragement, I'll do it. So I promised to talk about the heart as a pump, okay? And this is the heart failure, the kind of congestive heart failure, systolic heart failure measured with the number called ejection fraction. Do you guys know your ejection fraction? Anybody had echocardiogram? So it's amount of blood ejecting from the ventricle, and everything 55 to 65 is normal. When I tell a patient, your ejection fraction is 55, thinking I'm conveying good news, the patient looks at me and says, what do I do to make it 100? You don't want it to be 100. This is the optimal thing. But then the ejection fraction is how much blood is ejected from the ventricle. The ventricle, if the ejection fraction goes down, then the heart dilates, the patient may have the same amount of blood flowing just by compensation because their heart dilated, right? So may keep up good medications, all that stuff, they still may have good outcome. Now, normal heart volume is about 150 milliliters, normal ejection 70 milliliters. Look at the heart, what happens when there is a long-standing high blood pressure, right there. See the walls thicken? And a problem is that when you have high blood pressure, the heart has to work harder. The hypertrophy goes to the inside of the heart, not to the outside. And what's inside? It's the pump volume, right? So you may have normal ejection fraction, but because your end filling volume is low, you still have trouble. That's the essence of diastolic heart failure. Remember, I was talking about heart being a pump squeezing forward and then relaxing. The heart, when it's hypertrophied, when the blood pressure was not treated for a long time, it doesn't relax. The muscle is fibrosed, and it doesn't have this relaxation which should be there, okay? So those patients, they are fine when they rest, they make couple steps, they're short of breath, okay? So that's the heart failure, diastolic heart failure. So in conclusion, live well, think prevention, don't ignore symptoms, diagnose problems early, treat it like you mean it. When you get those medications, you take them. And live well for a long time. Thank you so much.
Thank you, Dr. Pizlo. All right, Kunga and I will be coming around for questions. I urge you to make your questions generic. Dr. Pizlo will be here afterwards. So if you have a personal symptom, don't ask that in the question because this is videoed and it goes up on YouTube. And so, all right, so do we have questions?
Just a quick one. So if you're on heart medication, I'm pretty loud.
Please, I want you each to talk into the microphone because this is being videoed.
If you're on heart medication, is it important to get the dosage 12 hours apart? If you take a morning and an evening medication, is that important?
It's important to space it if the medication is twice a day, because if they're developed to be twice a day, then their pharmacokinetics is such that it needs to be taken twice a day. The industry is making all efforts to make medications once a day because it's clearly easier to be taken, but there are still some excellent medications which need to be taken twice a day. And yes, it's important to space them.
Okay, here, first her and then you.
Hi, I work actually in sleep therapy, and I have a food company. That's a whole long story. So for the sleep realm at night to repair your heart, do you want it to be 4 hours or 6 hours of deep sleep realm? And then my other question is, what do you feel about the purest form of coenzyme Q10 for heart support?
Yes. So I'm not a sleep specialist, so the REM phases of sleep are not my forte. I want the patient to be well rested. So REM phase of sleep is very important for resting, for your brain to work and not feeling fatigue. As far as coenzyme Q10, there were multiple attempts to document their efficiency. And at this point, we know that it doesn't harm. Some patients feel very good on them, and I'm not saying no to taking it, but there is no sort of guideline-driven recommendation for it. But I'm not opposing to it because some patients do feel better when they take it.
We have another question over there. Go ahead.
Yes, I know UCI has a Susan Samueli Integrated Health Institute, and they have an integrated cardiology fellowship. And what do you think about this integrated treatment, lifestyle, stress management, nutrition, mind-body therapy, and also they have a testing, functional testing for ApoB and some heart rate variability testing. And
Yeah, you're talking to a program director of Integrative Cardiovascular Fellowship.
yeah, and
They will think I planted you there.
yeah. And also the supplement people
Yes.
should take like a
Yeah.
PPQ and a ginkgo and a garlic. These are B complex.
Yeah. So we are very lucky to have Susan Samueli Integrative Health Institute. And I hope that all of you guys are kind of going to the website and looking at their meditation classes and yoga classes, which they share with everybody. They have phenomenal kitchen. And all subspecialties are now practicing in Susan Samueli, including cardiology. We work closely with naturopath doctors, And we believe in all the modalities. We are not naturopathic specialists, so this is a purely collaborative endeavor with them, and we educate each other, and all the recommendations for for supplements or vitamins are very individualized by the naturopathic colleagues. So we practice cardiology with emphasis on well-being, and we refer to our naturopathic counterparts to enhance according to patient wishes.
Thank you. Okay, go ahead.
I had a question about the anti-arrhythmia drugs. I mean, that was a category on your
Yes.
slide. If you could talk a little bit about that, as well as the pros and cons of ablation.
Mm-hmm. So that depends on what kind of arrhythmia we are talking about. When you're talking about atrial arrhythmias coming from upper chambers of the heart, the mainstay of therapies are calcium channel blockers and beta blockers, because those are usually extra beats or fast beats, and those usually are sufficient to manage those problems. Now, when you're dealing with high recurring atrial fibrillation, then electrophysiologist colleagues dealing with electrical system may recommend some more advanced therapies there. And there are medications like amiodarone, flecainide. They're all kind of very patient-oriented according to their risk profile. And those are more advanced electrophysiology decisions to make. Now, if the patient's symptoms are managed with medications which don't cause side effects, then continuing medical management is appropriate. Now, if the patient has recurrent symptoms, does not tolerate medications, or the medications are not providing sufficient symptomatic relief, then ablation is an appropriate next step. And you can ablate atrial tachycardia, atrial fibrillation, atrial flutter. You can eliminate extra beats. Now, when you're talking about arrhythmias coming from the bottom part of the heart, this is a higher level of difficulty, right? And then the whole evaluation has to concentrate on why does the patient have those arrhythmias? Are they life-threatening? Are they a secondary thing to some other disease, like sarcoidosis may be causing arrhythmias coming from the lower chamber? Are they effect of the prior heart attack? So those are also, you look at it from that perspective. Hope I answered your question.
So I have a question with, I know with, if your ejection fraction rate does improve, a lot of physicians still say you need to be on medications for the long term, for life. So I was wondering if these medications, heart medications, are they more like just short-term acting, or do they have any long-term permanent improvements for that, or is it all mostly just short-term?
So let me rephrase the question. And correct me if I misunderstood. So if the patient had reduced heart pumping function, is that what you're asking?
Yeah, and then
yes,
improved.
and then improved. So this is a good question, and it's a complex answer. Because if the heart improved, normalized, let's say, right? You ask yourself, is it looking normal right now because you're on medications? And what will happen if you stop them, right? I recommend for patients who presented with the heart failure with reduced ejection fraction to continue taking guideline-driven medical therapy for life. According to mantra, once heart failure, always heart failure. There is some vulnerability that heart has, which led to that reduced heart pumping function. Now the story changes if you don't tolerate medications, if you have side effects. Of course, this has to be individualized. And there will be no randomized clinical trial to put people in a group of, hey, let's stop them, and hey, this is like, there are those patients where the culprit reason was clearly identified and treated. They may entertain a little bit more lenient approach to medication. But there was a longitudinal follow-up in Great Britain done of patients who voluntarily stopped taking medications and what happened to them. And the recurrence of heart failure was significant. I can tell you from my experience that I recovered many pretty bad-looking hearts to normal ejection fraction. And I had probably 5 patients who went off the medications and came back. And second time around, this trick didn't work. That was the scary part for me. That it almost looked like it was that first time recovery was a shot, and then the second time around, I don't know if it needed more time or something else, but that heart was tired. So it's personal experience, more like an anecdote, but it was finally confirmed by that British study where they just followed people with recovered function who decided not to take medications. So I recommend that if a person has heart failure, to stick with those medications if they are tolerated well. Yes.
The concern that I have is in regards to communication with health practitioners. Will they be having a database where, I guess my concern is for those who are patients maybe going through depression or have learning challenges and keeping up with information from different doctors can be a challenge. Is there a database where your cardiologist, your primary care, different doctors have a universal communication system so that when there are medication changes, that can overlap with another doctor, there can be proper communication?
I wish, right? I think that there was a congressional mandate to kind of have universal medical record. Currently, most common electronic medical record is Epic, and more and more systems are on the same platform, and I think down the road we just should have one electronic medical record nationwide, right? So, and I can tell you that it's not depression or education or anything. Everybody's confused about their medications, right? So, and about their recommendations, et cetera, et cetera. So, yeah, we need to have universal platform. Yes.
Regarding the blood pressure taking, when is the good time to take the baseline number? Is it morning and also?
It can be any time.
Any time during the day?
Provided that you have at least 15 minutes of downtime. So you need to kind of relax, not watch the TV,
relax.
Not watch the news. And check your blood pressure.
Thank you very much, Dr. Pizlo. I hope you stand here for a while, so if people have specific issues, they can come up and talk to you. This was going to be our last question, but all right, I'll let you go one more.
Mine's a current
don't have heart issues, but my late husband did. So how do apps work? And this ties in, this ties into current day, and thanks for answering. So they have like apps for bradycardia and tachycardia that people have. How does that tie in to help people manage their stress level and their heart issues?
So, you know, it's a new thing, right? We have quite a few emergency room visits, which are called Apple visits. This will improve. I believe in baby steps, and people are monitoring their heart rate, they're monitoring their sleep, they're bringing this data to me, and when they have it, it's wealth of information, right? So I love data. Give me data, I will get smarter, right? So this really is helpful. And I believe in this technology to improve. Now, there will be always some patients who will not tolerate it because it will drive them crazy. But many people are pretty religious about it, and some people are very religious about it. And I think that is contributing to some anxiety. So it's a spectrum. But
Sorry, what about the ring that ties in that people can monitor things? You know, the one they sleep with?
yes, I saw the patients wearing them. I'm not sure what I think about it. no
All right,
experience.
thank you, Dr. Pizlo.
Thank you.
And thank you all for coming. This will be up on YouTube and on our website. And next month, on March 24th, we will be talking about colons and liver disease.